Good morning, everybody. Welcome to Surgery Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you are attending virtually, you may enter your question into the Q&A section. A link to the survey will be shared in the chat section toward the end of the program. If you are ABS certified and want us to report your CME credits to ABS, please fill out the evaluation and give us permission to do that. And now it's my pleasure to introduce our speaker. Dr. Louis was born and raised in Egypt. He completed medical school at New York Institute of Technology College of Osteopathic Medicine. Dr. Louis has a special interest in minimally invasive surgery, bariatric and foregut surgery. Please join me in welcoming Dr. Mena Louis.
Good morning. Today I'm presenting bariatric and metabolic surgery, outcomes and complications. I have no disclosures. My objectives today for you are understand the role of bariatric and metabolic surgery, review the most common types of bariatric operations, review the complications that general surgeon may encounter in bariatric surgery patients, and review the workup and management of the common post-operative complications. This is a WHO classification of obesity. Normal weight is about 18.5 to 24.9. Diagnosis of obesity starts at BMI 30 to 34.9, then obesity class 2, 35 to 39.9, and class 3 over 40. Current US statistics, right now there are 50 million overweight, 40 million obese, 3 million morbidly obese, and 280,000 obesity-related mortality annually, and over 93 billion in annual healthcare cost. And only 1% of the eligible patients are undergoing surgical intervention. This is a list of the comorbidities associated with overweight and obesity. As you see, obesity has a lot of stress on all the organ systems. These comorbidities include type 2 diabetes, cardiovascular disease, hypertension, cholelithiasis, GERD, sleep apnea, certain cancers, and increased early mortality. The indications for bariatric surgery, the 1991 National Institute of Health Guidelines for Bariatric Surgery stated that the BMI over 40 or over 35 with associated comorbidities include type 2 diabetes, hypertension, sleep apnea, and osteoarthritis. However, the ASMBS in 2022, they released new guidelines and they lowered the BMI by 5, so it's BMI more than 35, regardless of comorbidities, or between 30 to 34.9 if the patients have at least one significant metabolic disease or comorbidity. Medical problems resolved or improved after bariatric surgery, type 2 diabetes, hypertension, sleep apnea, GERD, osteoarthritis, alcoholic liver disease, non-alcoholic liver disease, cardiovascular disease, mortality, and of course, quality of life. These are the commonly performed procedures in US right now that we will discuss. Vertical sleeve gastrectomy, Roux-en-Y gastric bypass, biliopancreatic diversion with duodenal switch, single anastomosis duodenal ileal bypass with sleeve gastrectomy or CDS, and laparoscopic adjustable gastric band. This is an estimate of the bariatric surgeries in US. This is the most updated one I found on the ASMBS website. As you see, sleeve gastrectomy is the most commonly performed procedure, followed by Roux-en-Y gastric bypass. Then band is out of favor, but still being performed by some surgeons in US. Then comes duodenal switch, revisions, SADI, one anastomosis gastric bypass. Worldwide, sleeve gastrectomy is still the most commonly performed procedure. Then comes the Roux-en-Y gastric bypass. The third one is the one anastomosis gastric bypass. And if you wonder what it looks like, this picture, The way you do it, you create a long gastric pouch, then you bring a loop of jejunum without transecting it, and you connect it to the pouch. I will be talking a lot about the complications, so I wanted to remind you that these are very safe procedures. The mortality rate is 0.1%, morbidity 2 to 3%, readmission rate 5%, and average length of stay 2 days. This is a study published in 2014 looking at the post-operative complication rate of 8 procedures. And if you look at the bottom, you see Roux-en-Y rate of complication 3.4%. It's even less than lab chole. This is another study based on NSQIP data comparing sleeve versus lab chole, looking at mortality and the complications, and they found that laparoscopic sleeve gastrectomy has 1/3 the 30-day mortality of laparoscopic cholecystectomy. How do these surgeries work? Some of them are restrictive, some of them are malabsorptive. Restrictive when they reduce the stomach size to limit food intake, as a sleeve gastrectomy and adjustable gastric band. Malabsorptive when they bypass part of the small intestine to reduce absorption, as in Roux-en-Y gastric bypass, duodenal switch, and SADI. Next, I will discuss all the procedures, how they are performed. The first one is sleeve gastrectomy. This is a restrictive procedure. It provides up to 65% excess body weight loss at 1 year. It is the most common bariatric procedure in US and worldwide. The way you do it, you start at the greater curvature of the stomach, at the junction of the body and antrum. You divide the gastroepiploic vessels, then you divide the short gastrics up to the angle of Hess. Most surgeons place 36 French bougie or VZG, same thing. Then you perform a leak test. Next one is the gastric bypass. It provides up to 75% excess body weight loss at 1 year. This is especially useful for type 2 diabetes and GERD. The way you do it, you start at the ligament of Trides. You measure 50 centimeter on the jejunum. You transect the bowel. Then you continue measuring 150 centimeter distally. At this point, you create the jejunostomy. Most surgeons place 36 French bougie and they create the gastric pouch. Then you take the distal end of the transected bowel and you create the gastrojejunostomy. So if you look here, here is the esophagus. This is the gastric pouch. Here is the gastrojejunostomy, anastomosis. This part of the jejunum is called the Roux limb. Here is the gastric remnant. You follow the remnant here, the duodenum. This part is called biliopancreatic limb. Both of them connect here, jejunostomy, and this is the common channel. Most surgeons bring the Roux limb in front of the transverse column mesentery. This is called anticolic. Sometimes you bring it up and it doesn't reach or under tension, so you have to make a hole in the transverse column mesentery, and it's called retrocolic. Average length of the biliopancreatic limb is 50 centimeter, and the Roux limb about 150 centimeter. Biliopancreatic diversion was duodenal switch. This is a combination of Roux-en-Y the Roux-en-Y and sleeve gastrectomy. It provides superior weight loss in the super obese, BMI more than 50, and it provides high weight loss, 79% excess weight loss, and it is the highest among bariatric surgeries. It also provides superior resolution of the metabolic comorbidities in BMI more than 50 compared to gastric bypass. How you do it, you start from the terminal ileum, you count retrograde 300 centimeter, and you mark the bowel with a stitch. Then you create a sleeve gastrectomy. After that, you divide the duodenum 2 to 3 centimeter from the pylorus. Then you divide the ileum at the point you mark it with a stitch. You divide the ileum here, and you already transected the duodenum 2 to 3 centimeter from the pylorus. Then you bring the distal end here up, and you create the duodenoileostomy, and here you create the ilioileostomy. This is the sleeve. You follow it down. This is the root limb or alimentary limb. The other limb here, continuation of the duodenum, is the piliopancreatic limb. Single anastomosis duodenal ileal bypass with a sleeve gastrectomy, or CDS. You also start as a terminal ileum. Then you count retrograde 300 centimeter. You mark it with a stitch. Here you mark with a stitch. Then you create a sleeve gastrectomy. After you do that, you transect the duodenum at D1, 2 to 3 centimeter from the pylorus. Then you bring the loop that you marked with a stitch without transecting, and you create duodenoileostomy. Next one is laparoscopic adjustable gastric band. It can provide excess weight loss up to 45 to 50%. How it works, it creates a small pouch above the band, about 15 to 20 cc, and the tubing is brought out through one of the trocar sites secured on the abdominal wall with a port that can be accessed to adjust the band. Due to high complication rates, the procedure is out of favor, still performed by few surgeons. If you take a KUB to look at the normal orientation of the band, this is the device here. It creates an angle with the midline. It's called phi angle, and the normal angle is 40 degrees. Complications. This is an interesting article published in Canada in 2022. They sent survey to general surgeons asking how comfortable they are dealing with the bariatric complications. 25% of them didn't feel comfortable dealing with bariatric complications, and 67% agreed that managing bariatric complications should be within the general surgeon's skill set. Complications of sleeve gastrectomy, staple line leak, the most common location at the proximal staple line, and I will discuss this later. Next, bleeding along the staple line. Then comes stenosis and the stricture. GERD can happen up to 20%, and GERD symptoms may develop or worsen after surgery. So if you see bariatric patient presenting with GERD symptoms, sleeve is not the appropriate procedure for them. Roux-en-Y gastric bypass, complications can be early or late. Early complications, pulmonary embolism is the leading cause of perioperative mortality. Anastomotic leak, most common location at the GJ. Obstruction can happen at the GJ or JJ. Bleeding less than 1%. Late complications, small bowel obstruction is the most common late complication. Marginal ulcer usually occurs 4 to 6 weeks post-op. Anastomotic stricture mainly at the GJ. Gallstone formation, 22 up to 71%. Some surgeons choose to perform laparoscopic cholecystectomy even a few weeks before the bariatric procedure. Most common cause of readmission in the first 30 days is dehydration. Duodenal switch, early complications, still pulmonary embolism, leading cause of perioperative mortality. Anastomotic leak, 2 to 5%. Small bowel obstruction, 2 to 3%. Bleeding. Late complications include malnutrition, vitamin deficiencies, and protein deficiency. Complication of CDS, leak, 1 to 3%, mainly at the duodenal anastomosis or sleeve staple line. Nutritional deficiency, diarrhea and malabsorption. Bioreflux. GERD, because you created a sleeve. Small bowel obstruction, 1 to 2%. Complications of laparoscopic adjustable gastric band, band slippage, band erosion, port and tubing complications, 10 to 15%. Esophageal dilation due to pressure from the band. GERD, 20 to 30% due to band pressure on the stomach. And weight regain up to 50% with 5 years. The most common cause to undergo gastric band removal is not all these complications, it's the dysphagia. The first one is venous thromboembolism. It is the leading cause of mortality after bariatric surgery. Rates are low, less than 1%, but they can increase with high BMI, more than 50, CHF, male patient, operative time more than 3 hours. 80% of these complications diagnosed after hospital discharge and within 30 days. Diagnosis for DVT, you obtain Doppler ultrasound. For PE, CTA pulmonary. Prevention with early ambulation, SCDs, Lovinox or heparin. And some patients will require extended DVT prophylaxis 2 to 4 weeks for high-risk patients. Management, if you confirm VTE, you start full-dose anticoagulation, Lovinox or DOAX. Massive PE, you consider thrombolytics or catheter-directed therapy. Leak, in case of Roux-en-Y, it's about 1.5%, usually at the gastric jejunostomy. In a sleeve, 2%, usually at the proximal aspect of the stable line or angle of His. Always maintain high index of suspicion when you see these patients because they don't always present with abdominal pain or fever. The body habitus of these patients makes physical exam less reliable. Tachycardia is the earliest and most sensitive exam finding, and diagnosis of leak with CT scan, IV contrast, and oral contrast. In case of a sleeve gastrectomy, when you perform the sleeve, this is the area I highlighted here. This is called the incisura angularis. If this is narrow, it creates a high pressure system, and it usually leaks here at the angle of His or the proximal staple line. Leak can rapidly lead to sepsis. Management of anastomotic leak, if it is a small contained, can be managed with image-guided drain, broad-spectrum antibiotics, bowel rest and parenteral nutrition. For hemodynamically stable patients, you can try endoscopic intervention, including stent or clips, IR-guided drain. For hemodynamically unstable or large uncontained leak, may require abdominal exploration, washout, and suture if possible, versus revision of the anastomosis. Bleeding, usually at the stable line, can be intraluminal or extraluminal. Intraluminal, in case of gastric jejunostomy or a sleeve, patients present with hematemesis. In case of jejunostomy, bleeding and the blood clots can cause obstruction or melena. For extraluminal, patients present with hemorrhagic shock. CTA can help define location, extend, and active extravasation. Management of post-op bleeding. Some bleeding can be managed non-operatively in case of a stable patient and responsive to initial resuscitation. Intraluminal bleeding in case of JJ or a sleeve can be diagnosed and treated with endoscopic approach. For intra-abdominal bleeding may require laparoscopic intervention for control of bleeding and hematoma evacuation. Marginal ulcers usually present 4 to 6 weeks after gastric bypass. The pathophysiology is vulnerability of the jejunal mucosa to acidic gastric juice. Risk factors is smoking, NSAIDs, large gastric pouch, more than 6 centimeters because it will contain some retained parietal cells in the distal aspect of the pouch. Symptoms, patient present with vague epigastric discomfort, nausea, PO intolerance. Diagnosis is EGD, and this will usually resolve with PPI, Carafate, avoid non-steroidal and the smoking, and treat H. pylori. If present, then repeat EGD. If refractory, may require revision of the anastomosis. These marginal ulcers can perforate, and perforation management is similar to perforated peptic ulcer. If it is contained perforation in a stable patient, can be treated non-operatively with bowel rest antibiotics and percutaneous drainage. Perforations requiring operative intervention, treated with gram patch and white drainage. Anastomotic stricture, usually weeks to months after surgery. These present with epigastric pain, regurgitation, reflux, vomiting, and PO intolerance. Risk factors, revisional surgery, ischemia, smoking, and use of circular stapler. These are diagnosed with upper GI and the endoscopy, and treatment usually starts with endoscopic balloon dilation up to 15 millimeter mercury. Tight strictures may require serial dilations over several weeks, and the chronic strictures failing dilations may require revision. Sleeve stenosis is the most common location at the GE junction and the incisura. Causes oversewing the staple line or creating the sleeve over a too small bougie. Diagnosis with upper GI and the EGD. The management is endoscopic balloon dilation. Refractory stenosis may require conversion to Roux-en-Y bypass. Small bowel obstruction. Diagnosis can be challenging and requires high index of suspicion. Causes, the most common one is the internal hernia, adhesions, JJ stenosis, port site hernia. These can present early or late. Early, within 2 weeks, due to JJ obstruction, port site hernia. Late, average about 21 months, and most commonly due to internal hernia, sometimes adhesions. Lapse, usually unhelpful. Imaging unreliable, but you can see a swirl sign. The gold standard for diagnosis is operative evaluation. Internal hernia, the cause is inadequate closure of mesenteric defect. Unfortunately, despite closure at the initial operation, can still occur. Presentation of internal hernia can be acute, subacute, or chronic. Acute when they present with bowel ischemia due to vascular compromise. Subacute, present with abdominal pain and vomiting. Chronic, present with intermittent abdominal pain, bloating, vomiting. CT doesn't usually show bowel obstruction, but sometimes can see mesenteric swirl. Diagnosis usually requires diagnostic laparoscopy. In case of Roux-en-Y, if the Roux limb is anticolic, you have two mesenteric defects. The first one is Peterson's defect, which is under the Roux limb between the cut edge of the Roux limb mesentery and transverse colon mesentery. The second one under the jejunojejunostomy and the cut edge of the biliopancreatic limb. If the orientation of the Roux limb is retrocolic, you have the Peterson's defect and the jejunojejunostomy as before, and you added a third hole through the transverse colon mesentery. Operative management of internal hernia, first thing you have to do is to reduce the hernia by running the bowel from the ileocecal valve and work proximal towards the ligament of Trides. Don't do the opposite. Assess all the potential spaces for hernia, including Peterson's space, JJ mesenteric defect, and the mesocolic space. Close the defect with non-absorbable suture. Gastrogastric fistula is an interesting complication. It is a fistula between the gastric pouch and the remnant stomach. Patients present with recurrent reflux and weight regain. The diagnosis is usually confirmed by upper GI or CT with oral contrast. If patients are asymptomatic, you can try to observe. And if they are symptomatic, you have to do revisional surgery. You can't just cut the fistula, you have to do in-block resection as the last picture. Adjustable gastric band complications. The first one is acute band obstruction. These patients present with PO intolerance. You take an X-ray, you see normal orientation of the phi angle. Diagnosis usually by upper GI, and the cause of this is tissue edema or band too tight. First thing you do when you see these patients in the ED is completely aspirate the subcutaneous port. Always use a Huber non-coring needle to avoid damaging the port, and band removal if no improvement. The second one is slipped band. Patients present with pain, nausea, vomiting, and bloating. Diagnosis with X-ray, upper GI, and CT. You will see a large portion of the fundus above the band, and the band lies nearly horizontal. The top one is the normal orientation of the band, and you can see the difference on the bottom one. Initial treatment, complete aspiration of the subcutaneous port. Then you have to remove the band. Band erosion. Usually these patients present with port site infection, as you see in the first picture. And port site infection is band erosion until proven otherwise. This is due to gastric wall ischemia from tight band or thermal injury during placement. Usually happens over time, so these patients are not very sick when they present. Diagnosis with upper GI study and EGD, and the treatment is band removal and perforation repair with omental patch. Next, we talk about the nutritional complications of bariatric surgery, the most commonly with Roux-en-Y and duodenal switch. All patients should be on multivitamins post-operatively and should have routine assessment with nutritional panel. Iron deficiency is the most common, and post-op screening schedule usually within the first 3 months, you check for iron. Every 3 to 6 months, you check iron, B1, B12, folate, and vitamin D. Annually, check B1, B12, folate, fat-soluble vitamins, iron, zinc, copper. The most important one I want to discuss with you is the thiamine or B1 deficiency, because it can be serious and life-threatening. Thiamine is a coenzyme involved in a number of metabolic pathways, and it has a role in nerve impulse propagation. It is a water-soluble vitamin and has short half-life, 10 to 20 days. It is absorbed in duodenum and proximal jejunum. If you see any patient, bariatric post-op patient, you can't figure out what's going on with them, just give them empiric thiamine. It is a water-soluble vitamin, so no risk of giving them extra dose. Always give thiamine before glucose to avoid precipitating wernicke's. If you look at the table here, this summarizes the clinical syndromes of thiamine deficiency. First one is the dry beriberi. This refers to neurologic complications, including peripheral neuropathy, weakness, tingling, numbness. Wet beriberi refers to the cardiovascular complications, including tachycardia, high output cardiac failure. Bariatric beriberi is the small intestinal bacterial overgrowth, or SIBO, and you treat with antibiotics to correct thiamine deficiency. The advanced form is Wernicke's, and it's a triad, ataxia, confusion, ophthalmoplegia. And the extreme one is the Korsakoff syndrome. This is the antegrade, retrograde amnesia, confabulation, and psychosis. These are other nutritional deficiencies, more nutritional deficiencies, and thank you.
Okay, thank you, Dr. Louis. Does anybody have any questions or comments? Just raise your hand, I'll bring the microphone to you.
That was an excellent presentation, Dr. Louis. Thank you. Very thorough.
Thanks.
Now, as you saw in the numbers you show, there's a lot of a kind of rebirth of the duodenal switch, and now with the SATI, a lot of people are doing it. But back in the day, when the procedure was started in the 90s, it got a really bad rep because of the nutritional deficiencies that it causes. Has there been any change in the procedure from the original back in the 1990s called the Scopinaro procedure to the current guidelines on how to do a duodenal switch or a SATI?
Based on my understanding, right now you start at the terminal ileum, you measure 300 centimeter. So you're giving them a very long common channel. So the nutritional deficiency is less than before.
Yeah, that's correct. So one of the things that the original Scopinaro procedure had was the common channel was only 100 centimeters. And that's what the problem lied. Now, going to 300, like you said, you do your duodenoileostomy there, and then when you go down to the ileoileostomy, you double the common channel. So now you do that anastomosis at 200 centimeters, and that had made a big difference nutritionally, and we're getting all the benefits of the procedure without the nutritional deficiencies. Excellent work, man.
Thank you.
Thank you, Dr. Louis.
Thank
Excellent
you.
presentation.
Thank
Have a
you.
great day, everybody.